Morning, everyone. Thank you for the opportunity to come to Montreal and to share with you the evolution of our province-wide coordinated strategy for the measurement of patient-centered care. And I want to start with a story. The title of my presentation is Statistics Without the Tears Wiped Off. And I want to tell you about this quotation. I had the opportunity in 2011 to present the results of a province-wide coordinated sector survey we had undertaken in our integrated mental health and addictions sector in British Columbia. And I was presenting the results, which we publicly released, when I had a question from a member of the audience who was a patient, a woman who suffered from mental illness. And in her question, she used the quotation, "You're presenting statistics without the tears wiped off." And I have to tell you that as a clinician whose career had progressed to focus on performance measurement, looking at system-level performance, moving from daily interactions with patients to working with numbers, I went home that night and I couldn't sleep. I thought to myself that when I had started my clinical career, I thought my future was so bright I needed shades, and what had become of the work that I was so driven to do, that everything I did was now based on numbers. And I then had a watershed moment because this quotation, statistics with the tears wiped off, in the world of Google we can now find out who says what, I learned was a quotation used by Dr. Irving Selikoff, a respirologist and a professor in the U.S., who used the expression when he was presenting against the asbestos lobby, when big industry had indicated that no, their statistics were showing that people were not dying from asbestos exposure. So I decided that it was my mantra and our mission in the province of British Columbia that we would present statistics without the tears wiped off. And the reason for that is because our guiding principle is that at the heart of every single data point in healthcare is a real person, a person with needs and wants and expectations, and that are especially important when they have healthcare needs. So I'm very proud to work in a province where we have mandated the collection of feedback from our patients in a scientifically rigorous manner that strives at every opportunity to engage patients and to make sure that when we present the results of our information that we do that keeping the individual person and the target population in mind. So patient-centered measurement in the province of British Columbia is a coordinated, cost-effective, because these are incredibly large-scale projects, scientifically rigorous provincial approach to the measurement of patient, and over time we've evolved also to family. We use a very broad definition of family supporters, of self-reported, what started as satisfaction, then evolved to satisfaction and experience, and now, based on some of the work of Nick Black out of the UK, we've learned that patients can and do discriminate between their satisfaction and their experience and their clinical outcomes. So we ask patients to provide their perspectives with no middle person of their satisfaction, experience, and outcomes. And we're unique in Canada in that we have a threefold mandate. We want to enhance public accountability, so performance measurement and monitoring at the system level, the macro level. But we also want to sample at the level of the unit so we can give clinicians and leaders information about what their patients had to say about their experiences and their outcomes at the point of care. So our sample plans are developed at the unit or level of care. And now, most recently, to inform research, and I'll be saying more about that. So for over 15 years, I was seconded in 2002 for a one-year project, and I was saying to my colleagues who are staying at the same hotel in the taxi today, it's now considered a permanent secondment because it's been for 15 years. We have solicited feedback from more than 1 million users of healthcare services across 13 sectors and subsectors across all ages. We collect quantitative, and I'll be sharing with you how we engage people to provide qualitative feedback and do analysis. But we learned that we could not be successful if all we did was disseminate results. We had to support action and the translation of data into information and information into action. And all our results are transparent and publicly reported. So I just want to have the caveat to say there are many, 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 many good ways to listen to what our patients have to say. And as a clinician, looking in the eyes of my patients and asking them for feedback is absolutely essential. But as you can see, there are many ways. What I'm focusing on my presentation on today is the provincially coordinated patient-centered measurement that we do in our province. So our beginnings were by looking at the literature. I myself was a Picker Fellow for 2 years, Picker USA, from 2004 to 2006. So I was very intimately aware of the work of the Picker Institute to develop the dimensions of patient-centered care. And interestingly, we've heard today about access, and access was not one of the original Picker dimensions. It was added afterwards when we recognized that being able to get services had become a problem. So we started our work around the time that the Institute of Medicine issued the To Err is Human, Crossing the Quality Chasm reports that were showing that there was a gap in what was happening in terms of scientific evidence and what was translated into practice. But we really, really, really struggled about what we should measure. So were we going to measure satisfaction? That's how we started. Patient-reported experiences, engagement, activation, patient-reported outcomes. We didn't learn about that till later. And even patient-reported incidents in the patient safety movement. And this is what we've landed on. Our mantra is PREMS plus PROMS, so understanding the experience of patients and their outcomes are better together. And we're really fortunate, and I feel personally very grateful that I work in the province where Dr. Rick Sawatsky, Canada's research chair in PROMS, lives and works at Trinity Western University. And together we have made it our mission to be able to look at what, from the patient perspective, they have to say about their global ratings of their overall satisfaction, the measures of their acceptability of the experience that they've had, as well as self-perceived health status and quality of life indicators. So this is the evolution. We started looking at just PREMS at the satisfaction level, quickly moved to PREMS for experience, then quickly realized that we also needed to understand subsectors, but we were committed to using core tools so that we could compare performance across the system. And then recognizing that when we looked at an analysis of our results across sectors and subsectors, the area that we consistently fell down from the perspective of patients was what we came to call continuity across transitions in care. And that was particularly relevant for patients with chronic conditions, multi-system conditions, etc. And we've then moved to implementing generic PROMs with every single sector that we survey in, and we're now moving towards blended cross-sector surveys that move along the episode of the patient's care continuum and looking at both generic and condition-specific PROMs. So this is a busy slide that you can look at in more detail, but just to show these are large-scale projects. When our Minister of Health and our Deputy Minister and our health authority CEOs say that they're interested in the perspective of patients in a particular sector, it's all in. You can't opt out. There's no cherry picking. Every single location of service is included. So this just shows the surveys that we've been involved in. This is our value chain, and again, you can look at this in more detail, but we never reinvent the wheel. If there is a validated, reliable survey instrument out there that meets our needs, we bring together academics, clinicians, frontline leaders, community stakeholders, and patients and families to select survey instruments. We develop the selection criteria, and then we do a gap analysis based on a conceptual framework that helps us to look at where are we missing important questions and dimensions in the context of the way care is delivered in the province of British Columbia, and then we develop and test additional questions. We only develop survey instruments if there isn't one that meets our needs, and that has been rare. We've even revalidated survey instruments to a lower age range if it's already been validated, say 18 and up, and we want to go down to 13 as we did in the mental health sector. Data collection, data processing, and reporting. And what you can see here by the color changes, we initially thought that if we did all this great work on selecting tools, developing tools, data collection, reporting, and analysis, that if we gave the results to people, they would just make the changes happen. And that didn't happen. And so you can see here the color change was we realized that we had to get more involved in the sharing of the results and the action planning. So now I'm not. So this is what I've said before, only when data has been analyzed, interpreted, and presented in a manner that makes it understandable and useful to others does it become information. Dr. Michael Murray was a personal mentor of mine from the University of Toronto and really, really supported the development of our initiative in the province of British Columbia. So along the way, we had some challenges. We had criticism about the timeliness of longitudinal retrospective surveys, the burden of the data we were dumping on people, and accountability. So part of that was the dissemination and the action on results. So we came up with our faster, better, easier to read reporting, with the solution being changing our reports so they wouldn't be statistics with the tears wiped off, with real examples from real people and their real stories. So our beautiful reports that initially looked like this, with confidence limits, run charts over time, that aren't they beautiful? What we ended up doing was we hired an analyst to join our team. This is an example of a monthly report in the emergency department, where instead of, on a monthly basis, giving people the 69 questions that were on the survey, we did correlational analysis, looked at relations to global indicator questions, the lowest performing questions, came up with a handful of 5, 6, 7, up to 10 questions that we provided information. And every single month, the analyst provided observations on what this month's data point was showing, asked prompting questions, and included a patient comment. So every question was looked at in terms of whether the scores were going up or going down or were flat. We would add a positive comment if the score was up, a negative comment if the score was going down, and 2 comments if it was neutral. We then did training across the whole province of British Columbia with leaders, frontline leaders and clinicians, and we taught them to lead with the patient comment, tell the patient's story, and then explain the data point. We've now moved to providing this electronically. So this is our dynamic analysis and reporting tool. The purpose of the DART is continual tracking of patient-reported experience and health-related quality of life experiences in what we call close to real time. It's designed to promote quality improvement at the point of care, 24/7 access with custom queries. The data is not weighted like our final reports are, and the data changes as new surveys are constantly added on a daily basis. This is just what it looks like. You get the DART count administration, and we get the results at a glance of all the global ratings. It's scrollable, it cascades, and it provides your score compared to the peer groups, shows the top performing questions, the lowest performing questions. You can print and save your graphs. You can go to another tab and you can explore the questions. So for every single question, you can see the scale, the responses, the top box score, and a run chart. Here's an example of one question. You can compare multiple questions in multiple tabs. You can then apply filters and look at your own patient population, and everyone gets access at either a health authority user, a facility user, or a unit level user. So we grant access. You can create tables and charts. Here's an example of reading a bar chart, and there's a tab with the patient's own words in the narrative comments that's in a searchable database, and they're coded into 6 categories and masked for personal information. So what has all of this data shown us? 15 years of data collection, the focus on transitions across the continuum of care, that from the perspective of the patients and families, that we want to be able to follow their journey across the continuum of care. And so just to show you again, in one of our sectors, the scores in continuity and transition were absolutely flat. While we were showing improvement of 8%, 10%, 15% in the other dimensions over time, in continuity and transition, the scores were absolutely flat. And so our patient advisors, too, here's again, true to our mantra of the patient voice, here's the voice of a patient in trying to achieve continuity. It's the patient who goes through the transitions. We are the packages that are handed from GP to the emergency department, from the emergency department to the hospital bed, etc. If nothing else, we are the ones who experience the errors, and we are the ones stuck with the consequences. Interesting, a lot of mostly informational errors occur precisely during the transitions. Errors always cost money and cause harm and pain. So we actually started looking at the literature, and we found right here at McGill, Jeannie Haggerty had done some work on continuity across transitions, relational continuity, informational and managerial continuity. And what we did was we tweaked, in British Columbia, we think we maybe do things differently or better. So we tweaked those definitions and came up with our own, with engagement from our patients. So here you can see the definitions. Then we started developing a module of questions that could be added to our existing sector surveys and eventually could become a blended survey. So we looked at conceptually assigning the themes that the patients and our clinicians and our survey results were showing us. Some, you'll see, were included in more than one area. We cognitively tested with patients and then did statistical testing for the alignment factor analysis. So we came up with questions and then we aligned them to the US HCAHPS tool, the Canadian survey instrument that had been developed across Canada with CIHI, and then our own questions under relational, informational, and managerial continuity. And the results are now in. So all of these slides you can have to look at those questions in more detail, but I wanted to highlight these. When we did correlation of the results of 24,279 people who gave us feedback about their acute inpatient experiences in maternity, pediatrics, rehab, and surgery across the province of British Columbia in all of our regions, 5 of the 8 questions with the lowest performance and the highest correlation to overall satisfaction scores, and that was best to worst hospital, best to worst patient experience, overall helped by my hospital stay and likelihood to recommend, were these 5 questions that came from our continuity module, showing that the areas that patients continue to tell us that we're not doing well on is continuity across transitions in care. So please join us. We are actually hosting the results of a 2-year CIHR-funded research project in British Columbia. There is a webinar to this, and we would love you to join. Chris Graham, the CEO of Picker Institute, will be doing this public address together with Isabel McKenzie, our BC Seniors Advocate, and Rick Sawatsky, our Research Chair in PROMS, will be joining. So after 15 years of tracking feedback from patients, we have this incredible data set. And I'm really excited about the fact that all of this data is moving to the Ministry of Health Central Data Warehouse Health Ideas in the province of British Columbia. And what that means is that it will provide access to researchers and our health authority analysts to be able to get raw data that has identifiers that will be made into meaningless but unique identifiers that can be linked to all the other data sets in Health Ideas. So after all of this time, we have 17.9 million records with identifiers that include the patient's, the information we used to conduct the survey results if they completed it, their open text comments, and then linkable to all of these other data sets that are currently in Health Ideas. And thank you to the Strategy for Patient-Oriented Research, which has given us $5 million to be able to do this work. So after 15 years of patient-centered measurement in the province of British Columbia, we continue to learn and evolve, and I feel really lucky to be working in a program where we can continue to change and develop. So what have we learned, where have we been, and what have we already accomplished? From PREMS data collection, only focusing on satisfaction and experience, to PREMS and PROMS, from presenting only numbers to numbers that are illustrated with stories from our patients, from data collection and reporting to supporting action and tests of change, and I'd love to have a whole day to tell you about our projects there, from data collection for QI and accountability to also making results now available to researchers. And on the horizon, We're just about to move from a sector location-based survey focus to asking patients about their experiences across their episode of care, back to the community, back to their GPs from hospital ED. Making available close to real-time as well as retrospective feedback. We believe that there are pros and cons to both types of data collection. Supporting and collecting point-of-care versus province-wide feedback. We're really interested in social media. Can it be more than a convenient sample? It's certainly the way to capture the voices of a younger population and provide building provincial capacity for patient-centered measurement versus our SPORE funding. We just put out a call for a chair for the lead of our patient-centered measurement methods cluster, and we're launching a website that will be publicly accessible. And we've come up with 3 tiers of data and 1 tier that will be available to the general public to access from our website. So Irving Selikoff said statistics are people with the tears wiped off, and I say statistics can be people without the tears wiped off. We published a paper on our evolution of our work, so there's the link. So thank you. Please let me know if you have any further questions.